All right. Hey, good evening, everybody. My name is Sean Holt with RC Health Services, and I'm going to be putting on a little bit of a presentation for you tonight um, regarding cardiovascular emergencies. Okay, so we're gonna see lots of different views, some examples of some of the effects of cardiac conditions, specifically myocardial infarctions or heart attacks, and we should have a pretty good evening. So I hope you all enjoy. All right, we're going to start off with an external view of the heart. All right, so this is what we're looking at, okay? This is the external view of the heart. If you've done some studying, you'll know that this red guy right here is probably one of the most important parts because it's the aorta, all right? The aorta is what pumps blood out to the rest of the body and is actually has the doorways to the coronary vessels. These vessels you see on the outside of the heart, okay, the external surface or the superficial surface of the heart. When there's higher pressure in the aorta than there is in the ventricles down here, whenever the ventricles contract, it pushes higher pressure into here and a valve snaps shut at the very base of this aorta. And when that valve snaps shut, that is called diastole. So this muscle right here relaxes, okay? During that relaxation phase is when the heart gets its blood flow, all right? So some of the things that we're looking at right here for the heart, we're looking at right here, this blue tube right here coming down. This is called the superior vena cava, all right? This down here usually would have a little blue tube to show the inferior vena cava, okay? But that is what leads to this guy right here. This whole section is the right atrium, okay? The right atrium of the heart is what collects all of the deoxygenated blood from the body that's returning from those distal cells in the body, whether it be a muscle fiber in your toe that needs oxygen, or whether it be a cardiac muscle inside of the heart. It all has to recirculate, collect back in the superior or inferior vena cava, and collect back into this right atrium. From there, it goes down to the right ventricle. Okay, it passes through a valve called the tricuspid valve. Okay, the tricuspid valve we'll talk about and see a little bit later on, but this is the right ventricle. The right ventricle is going to pump blood through what we call the pulmonary arteries, and that's these blue ones back here, okay? That and these over here. So obviously, looking at the anatomic position, these are the left pulmonary arteries. This is the right pulmonary arteries going into the right lung, okay? They're carrying deoxygenated blood from the right side of the heart, right? Where it just came from the body and has used all up the oxygen and has plenty of CO2 in it to be refreshed and gotten rid of. And then after it's sent through these blue vessels over here, okay, the pulmonary arteries, it goes through the lungs, all right? The lung tissue is what is going to get down to that alveolar level, the alveoli, refresh with external respiration, and it's going to refresh and put fresh oxygen into the bloodstream, okay? That is going to happen on a mass scale in both lungs, the right lung over here and the left lung over here, okay? But they're going to return to the heart after that through these red vessels that you see back here, okay? These are smaller and they get bigger and bigger as they get closer to the heart. These are called the pulmonary veins, okay? Usually, veins carry deoxygenated blood in the body, but in the circulatory system of the heart and the pulmonary system, that is the lungs, it's backwards, okay? That's because veins carry blood to the heart, right? While arteries move blood away from the heart, okay? So these blue vessels carrying deoxygenated blood are still called pulmonary arteries. but they're carrying deoxygenated blood. Okay. Once that deoxygenated blood gets to the lungs, returns back to the pulmonary veins, which are going to be filled with freshly oxygenated blood. Okay. And that's going to be moved over here to this guy. All right. I can only kind of show you this part. This is the left atrium. All right. And extends internally just a little bit, but it is a chamber that is eventually going to lead to this guy right here, the left ventricle. All right. We're going to see some pretty cool views of this tonight. So don't worry. This is not the only view you'll get of it. But in a nutshell, okay, blood comes back from the body, the superior inferior vena cava, comes to the right atrium, then is pumped to the right ventricle that goes to the pulmonary arteries. Okay, pulmonary arteries are carrying deoxygenated blood. That blood returns back from the lungs through the pulmonary veins, which are carrying fresh oxygenated blood, and those dump into the left atrium over here. Left atrium pumps it to the left ventricle, okay, and then it's pumped out the aortic valve into the aorta and out to the body. Okay, so you see these three vessels that are coming out of the aortic arch. These red ones, there's the subclavians and also the carotids are coming out of that aortic arch and heading up to the superior portions of the body. All right, like the head, the upper arms, the chest, the torso, and inside of, again, just the entry of the aorta itself are the openings to these coronary vessels that you see on the outside of the heart. That's what perfuses the heart muscle. Okay, so flipping it over, we're just going to take a quick look at the back, and we're going to see. Okay, so these red ones carrying oxygenated blood, that's why they're red. This is the left atrium. Okay, left atrium pumps down to the left ventricle, and that comes out of the aorta, all right, which goes to the body. So we're going to see this. We're going to talk about this again with a different diagram, but that is the heart in a nutshell in a 3D diagram. Okay, so the next part that I have for you to share are cardiovascular medications. All right, so we have 3 medications technically that we generally give to cardiovascular emergency patients. Okay, and the first of which is going to be oxygen. All right, we give that during the breathing part of the primary survey. All right, that's our ABCs, our general and our general impression initially, checking our level of responsiveness and all that. But we put on oxygen during breathing of our ABCs. So oxygen is our first drug. Okay, say this person, we verify, we think they are having a cardiac event. They are having chest pain that we believe is cardiac in nature. Okay, so what that means is they didn't get kicked in the chest by a horse. It's not trauma. Okay, it's not pleuritic chest pain. Remember the pleura? That makes for pleuritic chest pain. That is pain with breathing, all right, or changes with pain levels with breathing. We call that pleuritic chest pain. So if I was to take a deep breath, that would hurt. That's chest pain, yes, but it's not cardiac. It's related to breathing. Okay, cardiac chest pain generally isn't going to change with movement, palpation, or exertion. I mean, it's just generally going to be there, period. All right, it's just going to stay there and not get any better. Sometimes we can relieve a little bit of that pain with nitroglycerin, which we're going to talk about in a minute. But the first thing I wanted to share with you is our first med. Okay, besides oxygen, first med is aspirin. Okay, so what you may see here is an adult aspirin. These are big, ugly, nasty tasting tablets that you're, if you're having pain somewhere and you're instructed by a doctor or something to take aspirin, you would take one of these. It is 325 milligrams each. Okay, 325, remember that number, okay? But that's how much is in an adult aspirin, okay? These are coded tablets. So if somebody is having cardiac chest pain and they need a treatment for it, and we need to start treating it, sometimes they're going to be instructed to chew up these tablets so it's more quickly absorbed. It's absorbed faster, okay? What's even better than this, okay, a lot better than this, is our chewable baby aspirin. So I'm going to take away the adult aspirin, and we're going to look at the chewable aspirin, okay? So this is a bottle of chewable aspirins, okay? So let's open it up and take a look. Okay, those are the pills, and we're going to give 4 of them, all right? Because each one is 81 milligrams, all right? We see it right down here at the bottom. Let me see if I can autofocus. Yeah, so 81 milligrams each. What is 81 times 4? 324. Now, this was 325. So if you hear somebody say that they were given 325 milligrams of aspirin, I usually think, hey, they were given an adult aspirin or they chewed up an adult aspirin. If we say we gave 324 milligrams, it's because we gave the correct dose of 4 baby aspirin. They're chewables. They don't taste horrible, and they're 81 milligrams each, which is going to be 1 milligram less total than the adult aspirin, which we don't generally use, okay? Not for EMS purposes, okay? So these chewable aspirin are really what does and makes the biggest difference in our patients' lives, okay? If they're having a heart attack, aspirin is possibly the more important medication that this patient can receive in order to keep them from having a worsening heart attack, okay? So what that means is a heart attack is generally a spasm or a clot, all right? The clot situation in a coronary vessel. Remember, the coronary vessels are going to be these vessels on the outside of the heart that are perfusing the heart muscle. If a clot gets stuck in one of these, this aspirin is going to keep that clot from getting any bigger or new clots from forming. All right. So that's going to keep there from being more damage to cardiac muscle. Right. So here's aspirin, 324 milligrams, because that's 4 81 milligram tablets, chewable baby aspirin. All right. Now, after we've talked about oxygen and aspirin, okay, we're going to talk about nitroglycerin. All right. So what you can see, if you look really, really closely, I'm going to try to show it. It says 400 micrograms per spray on the spray bottle right here. Okay. But on these tablets, it just says 0.4 milligrams. All right. So 400 micrograms is the same as 0.4 milligrams. You just move the decimal 3 places. Okay. So 400 micrograms or 0.4 milligrams, this is the one I want you to remember, because if you can remember 0.4, you will know the single dose amount of nitroglycerin. These deliver the exact same amount of nitroglycerin, 1 pill versus 1 spray, all right? This is a meter dose spray, okay, which means that every time it's sprayed, it's going to give a metered spray, all right? That means 400 micrograms or 0.4 milligrams every spray that we're given, all right, or that the patient is receiving. So this is going to be sublingual, underneath the tongue, and you just simply, if it's indicated and you get orders from medical direction to give it, or you have standing orders to give this medication for cardiac chest pain, we're simply going to spray this 1 time underneath the patient's tongue, okay? They say with the spray, you can spray it on the tongue. And sublingual, which is what the route says, right? Nitroglycerin, lingual spray here. Here it's going to say sublingual. Nitroglycerin traditionally always goes under the tongue, because If you lift up your tongue and look in the mirror really close, there's a lot of vasculature underneath the tongue, not so much on the top. Okay. So these medications are meant to be absorbed through the mucosa underneath the tongue. Okay. They happen pretty quick, pretty rapidly, actually. Okay. 0.4 milligrams per spray, 0.4 milligrams per tablet. Now you'll notice the packaging is dark, right? This one's got a red covering to the spray bottle. This one has a dark coating to the glass bottle that it's in, okay? So let's look at these. Never touch or spray nitroglycerin with bare hands. I'm not going to put it in my hand and get it on me, but I wanted you to see how small these things are, okay? That is one nitroglycerin tablet, itty bitty, okay? One is all that they need under their tongue. We don't want to give more than that at a time, okay? But let's get that back in the bottle. Yep. And there's our nitroglycerin. Tablets are cheaper than the spray, so they're more commonly prescribed to patients, and they're more commonly given on the ambulance. But depending on the service, you might have the spray, which is just as effective, okay? Same dose as well. So do we have any questions on meds? Okay, remember, so one more time, oxygen, aspirin, nitroglycerin, all right? All right. The next thing I want to show you is the effects of nitroglycerin, okay? So this right here is part of an EKG, okay? Now what I'm going to show you are specifically the V leads. We call these the precordial leads. And this was taken at 0139, right? So 0100 hours and 39 minutes, right? 0139. So middle of the night, this EKG was taken, and this person is having a STEMI, okay? A ST elevation myocardial infarction. Now, the basic way that I can explain this is you see how over here on this lead, you got the spike that goes up and down, and then it's flat until it hits that next wave, okay? As compared to over here, okay? We have that spike, and then it doesn't go all the way back to the baseline. The baseline is this line right down here, okay, called the isoelectric line. That is the ST segment that's way up here, okay? So that's where we get ST elevation myocardial infarctions. If we see this in more than 2 leads as paramedics, that makes us start to hurry, okay? But this was at 1:39 in the morning, okay? I want you to look at it 6 minutes later after we've given nitroglycerin, okay? Where is the ST elevation now? Do you see any? Probably not, because I don't, right? There's no ST elevation 6 minutes after that first EKG because the patient received nitroglycerin, and it temporarily relieved the signs of ST elevation on their EKG, all right? But on this next one, we see at 01:53, which is 8 minutes after that, the nitroglycerin has worn off, and look at the ST elevation, right? So I'm going to lay that out for you real quick so you can see it all together maybe. Okay, we have multiple leads, 4 leads here with ST elevation, 1, 2, 3, 4. This one has no ST elevation because we gave nitroglycerin. And then 8 minutes after this EKG, the ST elevation has returned, okay, in V1, V2, V3, and V4, all right? So correlating with these EKGs was the patient's pain, okay? So lots and lots of pain here, temporary relieved for a short period of time here, EKG taken again once the pain started again, and we gave another dose of nitro, all right? I didn't get the EKGs because it was Very short trip to the hospital, and we knew exactly what this patient needed from the time we saw this EKG, and really by the time we saw the patient, because the patient was presenting with that classic cardiac chest pain look, pale, cool, diaphoretic, looks like they're hurting, complaining of severe chest pain or left jaw pain, neck pain, pain that radiates down their left arm, those kinds of things, okay? But it correlates with their pain. Pain here, no pain temporarily after nitro, and then the pain returned and we took another EKG and saw that again, okay? So hopefully that's entertaining. Just a basic look at what part of an EKG looks like. There's usually 12 different views. This is just like the second half of it. Usually there will be 2 more sections over here, okay? But I'm just showing the leads on this one that were affected, okay? Pretty cool, right? Any questions? Because that's all I've got for the docu camera. All right, I'm gonna place that away, and we are next going to start up on lecture. So we've gotten to look at the meds, we've got to look at the EKG, and we're going to start on the lecture. So give me just a moment to prep for that. Okay, should be sharing now. So going to start on cardiovascular emergencies. If you have any questions while we're going through this material in the chapter tonight, I just simply ask that you leave it in the chat, and I will keep my eye out and try to answer them. All right. So anytime, please feel free to ask questions in there. Right, so cardiovascular emergencies, this is chapter 17 of the 12th edition. So cardiovascular disease has been the leading killer of Americans since 1900. It accounts for 1 of every 3 deaths. Okay, so that's a third of the deaths out there. Okay, cardiovascular disease is a big killer, a big cause of death in adults and the elderly, okay, that have heart disease especially. EMS, emergency medical service, us, EMTs, AEMTs, paramedics, we can help reduce deaths by public relations. We can tell them, we can explain and show examples of why they should lead healthy lifestyles. We need to encourage that. We need to get early access to medical care, and we definitely need more people to be trained in CPR. Okay, so more CPR training of lay people. Quick opinion of mine, hate me or don't, I think that before anybody graduates high school, that they should have to go through a BLS class in their health class. Okay, if every person out there got to their senior level of high school, they'd be entering the workforce with a very, very valuable skill. Am I right? We need more people to be trained in CPR. So in the moment that person, walking in front of them in the mall collapses after clutching their chest and just goes unconscious, we know what to do, right? We don't have to call. We're going to call 911, or somebody's going to call 911, or we're going to say, hey, you call 911, you get an AED, right? That's a part of our BLS class that we're going to learn. But we're going to start working on the patient to make sure that they continuously have blood flow to not only power their brain, but to power their heart, right? The heart needs oxygen too. But those are the 2 big factors that we're worried about and that we really want to make sure keep perfusion. Otherwise, tissue starts to die. And once heart muscle and brain tissue die, they don't restore. Okay, so time is literally tissue. Okay, increase use of evolving technology in dispatch and cardiac arrest response. So what's going to be helpful in not needing to listen to the dispatcher walk us through how to do CPR. If we just know from training in high school, or as lay people start to learn CPR for jobs, or people that work in daycare centers or public schools or public institutions are required to maintain CPR cards, more people are going to live through cardiac arrest, sudden cardiac arrest, especially in the out of hospital setting, which is really mostly where these kind of things are going to occur. Okay. So it can happen in front of you. You may very well be that person that is in between that person's life ahead of them or their death. And that's not necessarily on you. Remember that people are going to die at some point, and we can't always save everybody, but we can certainly try to help, right? We try to help delay death of tissue of the brain and of the heart by getting them access to care as quickly as we can. Okay, so the evolving technology of cardiac arrest response is a big deal. Public access to AEDs, or defibrillation devices. They carry these in malls and public schools now, and places where large numbers of people congregate. Okay, recognize the need for advanced life support, and then the use of cardiac specialty centers when they are available. We talked about cath labs. Okay, we're going to see a video of what kind of stuff they do in the cath lab, and we're also going to see it in VR in a short presentation a little bit later. But these cardiac specialty centers are going to reverse heart attacks and give the best chance of survival to these patients. All right, so the anatomy and physiology of the heart. Okay, we're going to go through a little bit of the basic anatomy again, but we're going to skip through a little bit because by this point, hopefully, you'll have a basic understanding of the heart and the anatomy around it. So the heart's job is to pump blood to supply oxygen-enriched blood cells to the tissues. Specifically, oxygen binds to hemoglobin, right? That hemoglobin travels in those red blood cells and delivers oxygen to the tissues everywhere in the body, okay? So the heart itself, it's divided into left and right sides, okay? We saw that earlier, right here, right? We're looking at the left and the right, right? The superior and inferior vena cava dump into the right side of the heart. So if you ever see those blue ones coming off, that is the right side, okay? Versus the left side, which is going to be a little bit bulkier. The muscle tissue itself is going to be a thicker wall and stronger because it has more resistance, systemic resistance, meaning there's afterload. Okay, so afterload is going to be the resistance of the body that the heart has to contract against to send blood to all the tissues in the body. Okay, we're going to talk about that more tonight. The upper chambers, remember that's a 4-chambered but 2-sided pump. All right, so each side, the left and the right, if we're looking at the patient, has an upper and a lower chamber, right? These are the atria up here, and these are the ventricles down here, all right? So there's our heart. So remember, if the left ventricle is pumping out of the aorta, and the aorta will obviously be in a different spot than I'm portraying it right now, but if this is the aorta and it's pumping blood to the rest of the body, it's coming from that left ventricle. And remember that that left ventricle is going to be the strongest and thickest wall of the heart because of its constant resistance that it's having to pump against. It's always working out, right? It's never stopping. And if y'all remember some of my other lectures from earlier on, my diagram of, or my example of the heart always pumping really, really hard inside of your chest, but you're so used to it, you don't even feel it. This contraction is still going on in those ventricles. Okay, generally once to twice a second, 60 to 100 beats per minute. 120 beats would be twice a second, but generally 60 to 100 cycles per minute, and that's each contraction of those ventricles. Okay, first in one cycle the atria contract, and then immediately after the ventricles contract. That's our lub dub, right? Basically, all right. Here's an interior view. Okay, we're going to see some more of these later, but this is a great picture. Superior vena cava here in blue, inferior vena cava down here in blue, and where do they meet? Right atrium. Okay, from the right atrium, they travel through the tricuspid valve into the right ventricle. From the right ventricle, they travel through the pulmonic valve right here to go to the lungs. You see the right pulmonary artery and the left pulmonary arteries. Okay. At that point, the blood in the lungs that's getting pumped to the lungs from the right side of the heart is getting refreshed with external respiration happening at the alveolar level. Okay. But once that occurs and the blood passes back into the pulmonary veins that are carrying oxygenated blood, these red ones off to the side, right? They are going to be collecting in the left atrium, all right? Left atrium, you can't really see it too much. It shows a little bit of it right there, but that's because it's behind this really big pulmonary artery, all right? So really it's all behind right here. That's the left atrium, and that's going to pump through the mitral or the bicuspid valve because it only has 2 leaflets on it, whereas the tricuspid valve over here on the right side of the heart has 3 cusps on it. So mitral or bicuspid, you might hear them both. Understand that's on the left side of the heart. Okay. So after it passes through the mitral valve, it's in the left ventricle. Okay. The left ventricle, again, the strongest chamber in the heart because of the resistance it pumps against to go out the aorta up here. Okay. So naturally, the left ventricle pumps to the aortic valve. Blood passes through it. And then after the heart has completely contracted that left ventricle, the aorta up here is under a higher amount of pressure than the ventricles as they're starting to relax and refill with blood. Okay. So systole, do y'all remember a systolic blood pressure we learned about? So systole is ventricular contraction. Okay. Whereas after it's contracted, okay, it goes through ventricular diastole. Spelling it wrong. Diastole. Okay. So ventricular diastole is relaxation of the ventricles. And that is going to be refilling with blood. Okay. So if you can see me, remember, here's our ventricles contracting. Okay. They contract. I'm going to slow it down. Contract, that's systole. And then it closes the aortic valve because the aorta is under a higher amount of pressure than the ventricles once they start to relax. So they pump, then they start to relax, refill with blood. That's diastole. That's when the coronary arteries on the outside surfaces of the heart are getting their blood, their oxygenated blood into the heart muscle. Okay. That is when there is relaxation and refilling of those ventricles with blood so they can contract again the next cardiac cycle within a second, usually, right? All right, so that covers just about everything on this diagram. Are there any questions on this? Please type into chat and I'll come back to it. Okay. One-way valves keep blood flowing in the proper direction. Okay, the aorta, which is the body's main artery, receives blood ejected from the left ventricle. Here's basically an explanation of what I just did. I would suggest you come back and study it if you have a rough time kind of understanding where it comes from and where it ends up versus where it goes after it returns from the lungs, okay, and gets pumped out to the body. Okay, so basically this picture is saying body to the right side of the heart, and then from the right side of the heart to the lungs, then from the lungs to the left side of the heart, which will then go back to the body, and it repeats, right? So right receives, left pumps out, goes through the body, the systemic circuit. That's what we know the body as, and it returns to the right side of the heart. Now, besides the systemic circuit, we also have the pulmonary circuit. That's the lungs. That's everything in this part of this diagram, okay? The stage between the right and the left side of the heart, okay? It needs to go through the lungs to be reoxygenated. That is why those blood vessels are red. Those pulmonary veins are red coming back to the left side of the heart because they have fresh oxygen to be sent out to the body. The heart's electrical system controls the heart rate and coordinates the atria and the ventricles. I'm not going to spend too much time on this because I have a really cool virtual view of this that I'm going to show you all in a little bit. We'll slow it down and talk about that cardiac cycle a little bit more as the electrical activity is involved in this process. Okay, so yeah, again, electricity is what controls the heart, and it's not like a big shock. It's very, very small voltage, very, very small amounts of energy, but the heart is automatistic. All right, automaticity, or the muscle being automatistic, means that any cell inside of this heart, in the ventricles or in the atria, can start a cardiac cycle. But there's one spot, only one spot that we really, really want to be starting that impulse, and that's called the SA node, sinoatrial node. That beats 60 to 100 times per minute. All right, so 60 to 100 times per minute. All right, it can go faster, it can go slower, but ultimately what we want is a rate of 60 to 100 for a resting heart rate. Okay, so after the electrical impulse starts at the SA node, it's going to go travel down through the atria and recollect at a spot called the AV node. All right, the AV node is that second collection spot after the SA node, and then it goes to the ventricles. Okay, so automaticity allows spontaneous contraction without a stimulus from a nerve source, meaning the heart doesn't need the brain to tell it when to contract, okay, or when to send that electrical signal. That will make sense whenever we start to watch the electrical flow a little bit later in that virtual view that I'm going to show you, okay? But here is an outline of really what that electrical pathway looks like, okay? So SA node, sinoatrial node, starts right here. It's in the right atrium, okay? This is the right atrium over here, okay? All of this area. But it also has to travel through the left atrium too. So there's also electricity passing and then recollecting at this AV node. Okay, the AV node right here sits right between the atria and the ventricles. Okay, it pauses there for a second to fill the ventricles and top off the ventricles with an atrial kick. So the top of the heart, then the bottom of the heart contracts, right? Top, bottom, top, bottom, top, bottom. It just repeats just like that. All right. And the top and bottom, that's one cardiac cycle. That is one heartbeat, right? So if we're feeling 60 beats a minute on the wrist, that's 60 of that top bottom contraction. All right. The atrial kick, the top of the heart, is giving that kick of extra blood to fill up the top and top off the ventricles before the ventricles contract. Okay. So that can actually increase our stroke volume, if you remember that term, by 20%. Right. So that can really make the difference between strong, good blood flow and cardiac output and stroke volume and everything versus a situation where the top of the heart isn't contracting. Okay. That happens sometimes with certain individuals. Okay. We're not going to go into what it's called right now, but let's keep going down this track. So we have the internodal pathways in the atria, okay, in the left and right atria, but remember the SA node's in the right atrium to start with. Goes and that electricity collects in the AV node, travels down what they call the bundle of His. Okay, so it looks like His, but it's the bundle of His. Okay, and then splits between the right and left bundle branches. All right, so you see right bundle branch, left bundle branch. From there, it goes to the Purkinje fibers. So this is a lot of information. I recognize that. Okay. The more you hear the conversation we're going to have tonight, the more you try to pay attention, the more this is going to make sense to you later on. Okay. But understand that if we start at the SA node, that gives us a rate of 60 to 100 beats per minute. Okay. But say that this part of the heart dies and that SA node is no longer firing. It's responsible for the AV node now to start firing and causing that electrical impulse. Well, the AV node only fires 40 to 60 beats per minute. That's less than 60 to 100, right? So if this node fails, the SA node, we're getting a slower heart rate generally. Okay. So 40 to 60 beats per minute, not necessarily a good thing in most individuals, but there can be some very, very good athletes, some very athletic people that have slower heart rates because their body just doesn't need the heart to pump as fast because it's so effectively contracting. It can do it at a slower rate and it just does it safely. How do we know that slow doesn't mean bad? Well, we had to check a blood pressure, right? Check a heart rate, check a blood pressure. That tells us how fast the heart is beating and how well the contraction is contracting. Okay. So forget the Purkinje fibers. Don't really worry about all of them too much. Just know that if that AV node fails, just like that SA node failed, it's going to be somewhere in the ventricles that is having that electrical impulse start. Remember, because of automaticity, the ability of the heart muscle to create its own signal or electrical impulse. Maybe that impulse comes from right here, that red dot. Okay. Now that red dot is going to travel through the ventricles in another fashion that's going to take a longer time. All right. So has anybody, raise your hand? I know the video won't be able to see this, but raise your hand if you've ever felt your heart skip a beat. Right, where you feel like that fluttering, right? Yeah. What that usually is one of these, right? So for a second, maybe this SA node forgot to fire, forgot to go off or something, and you feel this impulse send electrical energy to the rest of the ventricles to contract to make up for that lost beat. Okay. Now, the difference between that is our heart is used to doing atria ventricles. Atria ventricles. Now, in this sense, it's just the ventricles. But the ventricles are normally used to pumping in the one specific way to direct blood upwards in the heart more superiorly, because that's where all the valves are, right? So it contracts normally from the apex down here, the point, the very bottom tip of the heart, upwards towards the aortic and the pulmonic valves, okay? So if it's normally used to being pumped in a certain way, like this, for years and years and years, and all of a sudden you have what we call a PVC, or an irregular beat, that's that fluttering, that quick, my heart feels like it skipped a beat. It's not doing that normal contraction. Instead, maybe for that one beat, it contracts sideways. All right? The electrical signal has flowed in a different pattern than it's used to. Now, you're used to your heart beating a certain way, right? But if for one beat, it beats sideways, you're going to be like, whoa, that felt weird. What was that, right? That's a PVC usually, right? If it's continued, people can actually go into different kinds of electrical rhythms, which is going to need EKG monitoring, which is done by a paramedic, okay, or the doctor in the facility in the ER, right? Lots and lots of things can happen with the electrical activity of the heart, but that's not something that we worry about too much. What we worry about as EMT-Basics is heart rate and blood pressure, right? We want to make sure that the heart is pumping effectively every time it pumps. We can tell that by heart rate and blood pressure and learning the stroke volume and cardiac output, okay? So that's the electrical conduction system of the heart in a nutshell. Now, the autonomic nervous system, ANS, okay, controls involuntary activities in the heart, in the body, in the entire body, okay? The autonomic nervous system is in the brain, basically, all right? It starts in the brain and sends signals or impulses for different things to happen throughout the body. But remember, the heart doesn't need the brain to tell it to pump or to send that electrical signal. So the heart is automatistic, and that's a special attribute of a cardiac muscle cell, okay? So the autonomic nervous system has two parts that it breaks down into, the sympathetic versus the parasympathetic nervous systems. Now remember this, sympathetic, fight or flight or freeze is how I like to remember it, right? If we get spooked, like somebody jumps out from behind a wall and goes, boo, right? Our sympathetic nervous system freaks out for a second and we feel our heart rate go up, our respiratory rate go up, we're freaked out, our hairs are on end, we can feel our heart beating really, really fast, and our muscles are actually getting more blood flow all of a sudden. So if we need to bolt, we have that ability without passing out once we start running instantaneously. The sympathetic nervous system is very quickly acting, okay? Now, in contrast, we also have the parasympathetic nervous system. This is going to be rest and digest, also known as bead and breed. This is when everything is slowing down, okay? Maybe during sleep, maybe during times when we're just sitting in front of our homework or our computer and our body's relaxing, we've just eaten a full meal, our GI tract is processing that meal, or we're going to the bathroom and nothing else really needs energy in our body except our bowels to move that bowel movement, right? So parasympathetic is that rest and digest, that feed and breed, okay? Parasympathetic slows, sympathetic speeds up. All right, the myocardium, or the heart muscle, cardium meaning heart, myo meaning muscle, must have a continuous supply of oxygen and nutrients to pump blood. Cardiac output, this is how much blood is being pumped out of the heart every minute. Okay, we can't calculate this exactly by like milliliters or anything like that without something called an echocardiogram, and we don't do that in the field. That's in the hospital setting or definitive care. Okay, but cardiac output can be estimated by saying, hey, we either have good stroke volume and an adequate heart rate, or we don't. Okay, how do we know if we have adequate stroke volume? Stroke volume is the amount of blood pumped out in one contraction of the ventricles. Okay, how much is pumped out of the heart in one contraction? How can we feel that? Radial pulse. If our heart's beating effectively, I'm going to feel a pulse in my wrist every time the heart beats. Okay, but my cardiac output is measured by taking that heart rate and that pressure or amount of blood moving out of the ventricles each contraction and creating that pulse wave, right? Our stroke volume is effective or it's not effective. It's either going to create that distal pulse or our blood pressure is low. Okay, our blood pressure being something like 120 over 80 or 140 over 90. That's all adequate, right? That's enough blood pressure, right, to continue to perfuse our body effectively. But say we hit something like 80 over 40 or 68 over, I should say like 36. These are extremely low blood pressures, okay? Generally, anything under 80, something like 68 or low 70s for the systolic, right? Systolic over diastolic. Anything less than 80 is not going to produce a radial pulse or a pedal pulse down in our feet, okay? We have to have sufficient stroke volume, meaning each contraction is pumping enough to create a pulse in our wrist or in our feet, right? For our distal pulses, or we don't have enough, right? Blood pressure's low, we don't feel it. Blood pressure's high, we probably don't feel it, right? Blood pressure's really high, we get something called a bounding pulse. A bounding pulse means you just lightly feel that radial pulse right there, and it feels like that vessel is just contracting like the heart is. You're going to feel it even if you press really hard on it. It is bounding, meaning it is super strong. Okay, so there's also thready. All right, thready is a term that we use to describe weak, hard to feel. All right, so if we're searching for a pulse, okay, and we're having trouble finding it, but we eventually find it, we consider it maybe a thready pulse. That's usually indicative of a lower blood pressure. Okay, not always, but most of the time. If we're having problems finding that radial pulse, it usually means that they're hypotensive. All right, so let me clear off this page and talk about the end right here. In the normal heart, increased blood is delivered to the myocardium by dilating or making larger the coronary arteries. The coronary arteries, again, perfuse the heart muscle itself, okay? So all of those cardiac cells, all those muscles in the walls of the ventricles and the walls of the atrium, they all need oxygen too. And it's not just absorbed from the inside of this, okay? It's not just absorbed through the inner walls. It actually has to go through these vessels, the coronary arteries, into smaller capillaries through the myocardium and deeper into the muscle itself, okay? But we have some main vessels in the heart that are perfusing the cardiac muscle, okay? Those are called the coronary arteries, all right? So you have the two primaries, right coronary artery and the left coronary artery. What do you think the right pumps to? Blood goes over to the right side of the heart. The left coronary artery covers a lot more area generally because it's a larger of the two vessels, and it actually splits at the very beginning from the left main coronary artery, or the LMA, left main. It splits to the circumflex that goes around to the back of the heart and the posterior portion of the heart, and the left anterior descending. Anterior meaning front, and descending meaning it's going down that left ventricle. Those are going to perfuse the anterior, the lateral, and sometimes a little bit of the bottom and the posterior surface of the heart with just the LAD. The circumflex is going to help with that. And then on the opposite side of the heart, okay, my right side of the heart, this coronary vessel going right here from that aorta, but coming around to the right, that is the RCA. And that is going to, that's the right coronary artery, and it's going to move blood to the right wall of the heart and the inferior wall of the heart. Okay, so the right coronary artery, the left anterior descending, the left main coronary artery, and the circumflex are all important to just have heard before. Okay, but really we need to remember that there's a left coronary artery and a right coronary artery, and only two different doors in the base of the aorta right here. Okay, two doors for those coronary vessels to receive blood during ventricular diastole, when the ventricles are relaxing and filling up with blood before the next contraction. All right. All right. So here's the left main coronary artery right here. Okay. You see how it goes. Here, let me change the color of my pen so you can really see it. I'm going to change it to purple. So here's the base of the aorta, right? The aorta actually has two doors. Okay, here's the right door. Here's the left door over here, right? Left versus right. So that left door opens up to the LMCA, the left main coronary artery. That's all that it is right there. It's from that door just to this bifurcation. Okay, from there it splits off. I'm trying to erase it. There we go. To the circumflex that goes around the back. Circumflex branch of the left coronary artery, and the left anterior descending. This guy right in the very, very anterior aspect of the left side of the heart. So anterior descending of the left coronary artery. We just call it the LAD. Left anterior descending. All right. All right. So this is the anterior view, the posterior view. Here's the circumflex coming around. Right. Here's the LAD going down here in the front, but this is the posterior view. Not a lot going on back there. Here's your superior and inferior vena cava carrying deoxygenated blood to return to the heart, right? To go to the lungs, come back to the left side of the heart, and go back out to the body. Not going to spend too much time on those extra diagrams because we've been pointing them out tonight. Not going to spend a lot of time to where different arteries in the body go. If you look at these femoral, we know that's in our leg, our upper leg, right? It's a pretty big vessel, okay? Radial and ulnar, we know that to be our radius and our ulna. So there are vessels, arteries and veins that go along those bones, right? These are pretty straightforward. Subclavian, beneath the clavicle. So that's a pretty big vessel, and one of them actually comes off, or one or two. I get mixed up with the carotids and the subclavians. But those three vessels that pop off the aortic arch right here, 1, 2, 3, I believe these are the left and right coronary arteries, and this is the subclavian that splits into left and right. I might have that wrong. I'm so sorry if I do, but there's only 3 coming off the aortic arch, and one of them splits. Okay, so whether that's 2 carotids and 1 subclavian, or 2 subclavians and 1 carotid that split and go up, I forget. I'm sorry, but we're gonna keep going past this slide and keep going. Arterioles and capillaries are smaller vessels. The capillaries are where blood and gas exchange occur in internal respiration. All right. Remember external respiration? This happens in the alveoli. This internal respiration happens in the tissues, right? The end organ tissues, we should say. So whatever cell needs that oxygen, it's going to get there during internal respiration, that trade-off of oxygen and carbon dioxide. Okay. Venules are the smallest branches of the veins before they connect or have connected from the capillaries. So it goes arteries. Actually, let me erase the screen real quick. So it goes arteries to arterioles to capillaries. Oh, there we go. To venules, then to veins. So large, okay? Both sides over here. Veins and arteries are the bigger ones. These are smaller, and these are the smallest. They're microscopic, okay? Meaning if you get a tiny little scrape on the top of your finger and you can just see the blood just kind of lift up out of the skin, that's a capillary bleed, okay? That's like very, very minor. All you have to do is basically like rub some dirt on it, keep on going. No, I'm kidding. Don't actually do that. There's lots of bacteria in dirt. But capillary, that's going to stop pretty easily, okay? An arterial bleed, this big, large vessel over here, is going to need probably a tourniquet if it's on an extremity, or it's going to need a lot of direct pressure, okay? You'll talk about bleeding in that chapter for trauma later on. But these are the vessels, arteries down to arterioles, down to capillaries. Then we have from the capillaries, they collect in the venules that collect into the veins. And the venules and the veins from here to here, all the way up to the back to the heart, are one-way valves. That's because the venous system over here is under a lot lower pressure than the arterial system over here, okay? Our arteries, whenever they bleed, they spurt bright red blood. Veins, which are just as large vessels usually, are under a lot lower pressure, and they're just going to ooze, okay? They're going to ooze, but they can ooze really, really fast too, like a femoral vein. If that gets nicked or cut or something from penetrating trauma, that can bleed very, very quickly because it's, I don't know, maybe around the size of my pinky, right? Cutting one of those can make you bleed out pretty quick. So direct pressure. We'll learn more about that in trauma. All right. So the blood. Blood consists of red blood cells, carry oxygen and hemoglobin, right? On the hemoglobin in red blood cells. White blood cells, they're WBCs, help to fight infection, okay? Platelets help the blood to clot. Now, y'all remember this guy? This is an antiplatelet. I hope you remember that from pharmacology, but an antiplatelet keeps clots from getting bigger or creating new ones in the first place. So these platelets are kept from aggregating, which usually is what they're going to do whenever there's a need for a clot, like at a wound or a laceration or something like that. But platelets are not our friend whenever we have a clot building in our heart muscle, okay, or building somewhere else in the body where they're not supposed to be, or if a clot is traveling to the brain, right? But we don't give aspirin for anything other than cardiac chest pain, okay? That is our only indication for aspirin in EMS, okay? It has its antiplatelet properties. Y'all remember? Hopefully y'all paid attention during pharm. If not, go back and learn about the drugs again in the pharmacology chapter. I think it's chapter 12, okay? Plasma is the medium, all right? The medium being the fluid that all these blood cells float in the blood, okay? So the plasma is the fluid which those cells float in. All right. Blood pressure is the force of circulating blood against the artery walls. There's a systolic blood pressure. That's the maximum pressure generated, remember, by the left ventricle, the strongest chamber of the heart, right? Because it's got the most afterload, the most resistance to blood flow afterwards, okay? So the diastolic blood pressure is that remaining pressure when the left ventricle is at rest, okay? When there's relaxation of the ventricles and that's refilling with blood, that's diastole, and that's when the heart muscle is getting its blood flow, its oxygen, okay? Now we know what a pulse is now. That's going to be during systole or immediately after systole of the heart or the ventricles, right? Contraction of the ventricles causes a pulse in the extremities, in the neck for our carotid, or a femoral pulse in our inguinal area, right? The crevice of our leg and our stomach where they meet. And then there are, so we have our central pulses or our peripheral pulses, okay? Central pulses would be carotids, brachials in kids underneath the bicep, and the femoral, which is down where our leg, top of our leg meets our waist, okay? That's central pulses. Peripheral pulses are going to be our wrists, our radial pulses, and our pedal pulses down at the very bottom of our feet. Well, not at the bottom of our feet, but it's on the top of the foot generally. We call the dorsalis pedis pulse, all right? So those are peripheral pulses in the extremities, okay? So central, think closer to the core. So here they show, here's feeling a femoral pulse. Generally when we have to do this, it's during something like cardiac arrest. And generally the patient is going to be less stressed whenever that's going on, okay? So it's not appropriate to take a fully awake patient and be like, I'm gonna check one of your core pulses. I'm just gonna reach down into your pants and feel your femoral pulse. Not a good idea. That leads to harassment charges. Not a good thing, right? So femoral pulse, generally for cardiac, can't spell, cardiac arrest, in parentheses, pulse checks. The other one that we can use in cardiac arrest is the carotid pulse in the neck, okay? Or if we can't feel a radial pulse, we can go to the carotid pulse, right? And remember, if our blood pressure is 80 or less, we may not even feel that radial pulse, okay? So that's when we go to the carotid and we're like, hey, I hope we feel a carotid, otherwise we're gonna be doing CPR, right? All right. Posterior tibial is on the side of the ankle, okay? Dorsalis pedis, like I talked about a minute ago, is on the top of the foot, generally right in the middle. It's kind of harder to feel, but once you feel it, mark it with a pin. Just put a little X on it so you know where to go to check it again later. Generally, that's in trauma patients, okay? Brachial is more for kids. It's harder to feel in adults, but it's super easy to find in anybody that's 5, 6 years old or under, okay? Infants, we check brachial pulses, not carotids. 1-year-olds, 2-year-olds, even 3-year-olds, we go straight for the brachial, okay? Straight to the brachial. 4, 5, 6, we can check a radial pulse because it's less invasive than pushing their muscle up to the side, their bicep up, and trying to feel a brachial. We might just start with trying to feel a radial, All right. And our last slide for this portion, cardiac output. We talked about this. This is the movement of blood out of the heart in 1 minute. How we get that is stroke volume, SV, which is how much blood is pumped out of the heart in one contraction, right? Multiplied times our heart rate, which is how many beats per minute our heart's beating, all right? This is the cardiac output is only measured by an echo, but we can consider something to be effective if we feel a strong carotid pulse at a decent rate and we get a decent blood pressure, something hopefully over 80. 80, 90, 100, that's, that's still pretty low. But anything less than 80, like in the 70s or in the 60s for an adult, that's not a good day. That's not a good day. Something's wrong. Okay. Perfusion, that term, it's the constant flow of oxygenated blood to the tissues that need that oxygen. So perfusion, we learned about in shock, right? Hypoperfusion is a state of shock. And if perfusion fails and the patient goes into shock, cellular and eventually patient death occurs. Okay. Shock leads to death. So we need to treat shock. There's a mnemonic that we use to treat shock. Don't forget your BOLT mnemonic. The blanket, oxygen, lay them down appropriately if it's appropriate, and transport, time to transport, rapid transport. All right. So pathophysiology of chest pain usually stems from something we call ischemia. Ischemia is decreased blood flow to tissues. Ischemic heart disease is going to be decreased blood flow to one or more portions of the heart. If blood flow is not restored, the tissue dies. This is in a myocardial infarction. Ischemia worsens to infarction, which is actively dying tissue. Okay. Just like you can have a cerebral infarction, you can have a myocardial infarction as well. So that's where we get MI from. Okay. So we have a normal artery up here up at the top. And then we have a narrowed artery. And I'm going to show you all a really good video of this later, a virtual view of this. So we'll go over this some more. Just understand that plaque can build in the walls of a vessel, calcium buildup as well. But this is stuff that can truly cause bad heart disease. So the calcium, cholesterol buildup inside of the walls of the coronary blood vessels, the heart's blood vessels, causes an obstruction in blood flow to the heart. All right, there's a thing called a thromboembolism. This is a moving blood clot. All right, so a blood clot that is floating through blood vessels. But if a clot lodges in a coronary artery or a heart's vessel, right, an acute myocardial infarction or AMI results. Remember, we talked about MI is just a second. You put the word acute before it, and you have AMI. AMI means happening right now. All right. So somebody may say, I've had a heart attack before, so they've had an MI, right? But if somebody's having one right now, they're having an acute myocardial infarction, and that needs treatment. Okay. Coronary artery disease, also known as sometimes as CAD. Okay. A lot of the time, actually, if you see CAD, think coronary artery disease or heart vessel disease. That's a leading cause of death in the United States. There are controllable risk factors that we can have control and influence over in our lives. But then there are uncontrollable ones that still will make us more likely to get risk factor or have an acute myocardial infarction. So controllable versus uncontrollable. Stop smoking. Control high blood pressure. Control high cholesterol. Work on your diabetes if you're a diabetic. Exercise more and try to lose weight if you are overweight. That's me, right? So an uncontrollable risk factor would be being of older age, having a family history of coronary artery disease may make you more prone to having it yourself. Atherosclerotic coronary artery disease, atherosclerosis, meaning that plaque buildup, right? Race, ethnicity, and males are generally more commonly affected by coronary artery disease. Now, there's also something that's not quite an AMI, but ACS, acute coronary syndrome. What it is it's a group of symptoms that point towards, say, an active acute myocardial infarction. Okay. So ACS is a group of symptoms like chest pain, shortness of breath, and just other, let me see, chest pain, shortness of breath, sometimes nausea and vomiting, syncope, where somebody collapses or passes out. Those are all acute coronary symptoms or acute coronary syndrome, right? Think of syndrome as being a group of symptoms, okay? Oh, I should go back. Angina pectoris is cardiac chest pain, okay? Angina is talking to pain because of the heart vessels. It's usually supply versus demand. Demand is higher than our body is able to supply, all right? All right, so angina pectoris occurs, again, when the heart's need for oxygen exceeds the actual supply for it. What that's going to feel like is generally crushing or squeezing pain. Angina itself does not necessarily lead to death or permanent heart damage, but is more of a serious warning sign that we need to be checked out by a cardiologist, okay? They have special studies they can perform. There are scans that can be performed, and they can evaluate your coronary vessels to see if you have coronary artery disease, okay? So angina will typically go away with rest, whereas a heart attack, okay, will not subside just by taking it easy, right? Angina pectoris can occur during, working out, exertion. Maybe you're working in the yard and mowing or something like that, and all of a sudden you're experiencing chest pain. Well, if you put down, the weed eater or stop the mower and go sit down for a few minutes and it goes away, it's typically angina, okay, and not necessarily an acute myocardial infarction. All right, so there are different types of angina. There's unstable angina. This occurs without exertion. So if you're asking somebody their OPQRST questions, what was the onset? What time was it? And what were the events leading up to? Or is it constant? Is it coming and going? Those kinds of questions. Unstable angina, you're going to find out that they weren't necessarily doing anything that required exertion. It's just happening at rest. That's not a good thing, okay? Stable angina occurs in response to exercise or activity that increases demand on the heart muscle. Typically goes away with rest, okay? Typically will go away with a nitroglycerin tablet if the patient has coronary artery disease and is prescribed nitroglycerin. People actually are prescribed it and will take it as necessary, okay? But we need to treat angina patients like they're having an acute myocardial infarction, all right? So we're going to give them aspirin, oxygen if they need it, and possibly nitroglycerin, okay? An AMI, acute myocardial infarction, pain signals actual death of cells in the heart muscle. Once dead, these cells cannot be revived. They are no longer available for contraction of the heart, right? That's not a good thing. We want every possible bit of our heart muscle contracting for us in order to keep us, with a good cardiac output, keep us awake, standing up, conscious, talking, thinking, all of that, right? If enough tissue cells die in the heart, our heart's not able to function. We go unconscious, we lose pulses, and we die. Our brain cells die, and there's no return from that. True acute myocardial infarctions are in fact very, very dangerous and sometimes deadly. All right. There are sometimes medications that they're going to give at the ER that can break up a clot. This is not as common nowadays as angioplasty. Angioplasty is going to a cath lab and them actually going into your heart vessels and clearing out a clot or opening up a spot that is spasming in your coronary vessels. Okay. If angioplasty occurs within the first few hours, it may prevent damage. Okay. May not stop some of the heart tissue from dying in an acute myocardial infarction. But if we can stop most of it or as much of it as we can, we're going to have less effects from that. Okay. Less permanent damage. So immediate transport is essential for somebody that's showing signs of an acute myocardial infarction. And these are those signs that I was trying to list off earlier and I was having a little bit of trouble with. So weakness, nausea, sweating, chest pain, discomfort or pressure, lower jaw, arm, back, epigastric, so upper part of your stomach, or neck pain. All right. So anything that goes on the left side of the face, down the neck, down the left arm, and starts in the chest is a classic heart attack sign. Okay. Take these patients seriously. Okay. Other signs would be an irregular heartbeat and syncope, which is also known as fainting or passing out. Syncopal episodes may be referred to as well. Shortness of breath or dyspnea, right? Problems breathing. And then we have nausea, vomiting. Again, nausea is up here too, but nausea and vomiting together can be a sign of an AMI. And then pink frothy sputum, which is going to indicate acute heart failure. We'll talk about heart failure a little bit later on. But also sudden death. Yeah. If a clot is big enough and it lodges right in the wrong spot, we're out. We are just plop, passed out. Our heart muscle is starting to die immediately, and unless we get perfusion started again, or a proper heart rhythm again, it can kill us. Okay. All right. So AMI. The pain is going to differ from angina. All right, it's not always due to exertion, but it will last 30 minutes to several hours. Okay, not always relieved by rest or nitroglycerin, and an AMI patient may not realize they're even experiencing a heart attack. Okay, some people neglect the pain that they feel in their chest whenever they're actually having a heart attack. And even though it may do as much damage as it's going to do, it may still be bad enough for them that they have a lowered ejection fraction. And the ejection fraction is something that is measured very closely in congestive heart failure patients or acute heart failure patients. And that's measured with an echocardiogram. They can also watch the walls of the heart, make sure they're all moving correctly and are the right thicknesses and things like that. Okay. AMI and cardiac compromise physical findings. So fear, yeah, the patient will be terrified. They're going to look at you and they're going to be like, "Am I dying?" And you're going to be like, "Maybe. Let's go try to get you to the hospital so they can keep it from happening." All right. Poor circulation, hypotension, or shock in some situations. Right. Cardiogenic shock can happen from an acute myocardial infarction. It just means that the heart, that's usually supposed to be pumping nice and strong, is not able to pump as effectively anymore, right? Because of dead tissue in the heart. Not as effective means that person is going to get tired even standing up and walking across the room to go to the bathroom, right? They're going to get exhausted. They're going to get short of breath. They're going to feel like they're going to pass out. They might even pass out in cases of extremely low ejection fractions or this poor circulation, right? Low blood pressure, low ejection fractions. We will talk about ejection fractions, I think, in a little bit, but it's not. You're not missing out if you don't have a full understanding of what that means in heart failure. Okay, so fast, irregular, or bradycardic pulse. So you might have tachycardia, you might have an irregular pulse, or you may have bradycardia or slow heart rates. Slow heart rates generally less than 60, fast heart rates over 100. Okay. The higher you get, the closer you get to 200, the more scared I get, right? I want to make sure that my patients are not beating at 180 times a minute because it's likely not coming, the signal's not coming from that sinoatrial node, the SA node at the top. It's likely firing from somewhere else that's really irritated and firing very, very, very quickly like that. All right. We'll see a virtual depiction of that later. I'll show you all what the heart is capable of in those irregular heart rhythms. So decreased, normal, or elevated blood pressure, any one of them can still be a sign of an AMI, right? You can have a normal blood pressure and be having a very bad heart attack. It may not be but a late sign that the patient is hypotensive, right? Normal or rapid and labored respiration, so working to breathe, right? Patients express that feeling of impending doom. That's when they look at you and go, I feel like I'm about to die. And you have to look at them back and go, I'm a little nervous now, because sometimes whenever patients say that, they're right. Okay? So that's impending doom. And that happens in other situations as well, not just heart attacks. There are 3 serious consequences of an acute myocardial infarction. We have sudden death, where the patient passes out, loses pulses, and suddenly, they're dead, and we're doing CPR on them. Cardiogenic shock, which can happen basically during an acute myocardial infarction. That pink frothy sputum that we talked about just basically earlier, pink frothy sputum meaning spit or basically like upchuck from the lungs, right? Fluid is overfilling the lungs and it's coming out of our trachea and getting spit out of our mouth, okay? What happens is the left side of the heart that usually pumps out to the body is under too much strain, or it's not pumping effectively. So the left side of my heart, if it's not pumping effectively, that blood that's trying to get through that left side of the heart is backing up somewhere. Now think about this. Where is it going to back up if it's stopping at the left side of the heart? It's going to be the lungs. Okay. Does burst stop before it gets to the left side of the heart to be pumped out of the to the body after it's made it through the right side of the heart? That stop is the lungs, right? So if we have left-sided heart failure and that starts to fill up our lungs with fluid because it's building up pulmonary hypertension or too much pressure in the pulmonary circuit, it's going to start to spill plasma and stuff into the lungs, and that can build up and build up and build up until it sounds like the patient is drowning in their own pulmonary edema. All right. So if you haven't heard that term before, I don't remember if we've gone over it, but pulmonary edema equals fluid in the lungs. Okay. Pulmonary edema. Edema usually means swelling. Well, in this case, it means fluid, and pulmonary means it's in the lungs. So pulmonary edema is fluid in the lungs. Now, you may see that with cardiogenic shock. And cardiogenic shock is usually because they're having an active heart attack, or they just had an active heart attack and it's already doing all its damage. But you may also get pulmonary edema with CHF, congestive heart failure. Congestive heart failure is the effects, the delayed, usually, effect from an MI. All right. So heart tissue dies. Okay. If it's on the left side of the heart, the left side of the heart's not going to be able to pump effectively anymore. That means fluid's going to back up into the pulmonary circuit and cause pulmonary edema. So CHF patients that know that they have congestive heart failure will generally present not with chest pain necessarily, but with difficulty breathing. Okay. Excuse me. If there is pulmonary edema in our congestive heart failure patient, we're going to be able to hear that with a stethoscope. Okay. It sounds like fluid bubbling through the alveoli. Remember, we listened to those lung sounds, rales, R-A-L-E-S, whether they're fine or coarse rales, also known as crackles. All right, so crackles is that bubbling sound, right, of fluid passing between the alveolar walls. If you hear that, think pulmonary edema and think maybe they have CHF. Okay. Ask them if they have congestive heart failure. Ask them if they've had a heart attack in the past. Those kinds of things are going to be very essential in really understanding what's going on with our patients. Now, a dysrhythmia is a heart rhythm abnormality. Okay. So this is that electrical activity that's throwing weird rhythms out there that may cause ineffective movement of blood flow through the heart. Okay. Or body. Premature ventricular contractions, we talked about those earlier. If we have one of them, it feels just like kind of like a skipped beat, right? It feels like our heart skipped a beat and we're like, oh, that felt funky. What was that? Or it's a quick flutter in our chest. PVCs can be natural, can be benign, meaning not dangerous. But if you're having a lot of them, go get checked out by your doctor or a cardiologist. Okay, it doesn't necessarily mean that you need to call 911 unless they are causing pain or discomfort, like happening a lot, like multiple times a minute, and you're feeling tired or something like that, or short of breath or anxious. That may warrant 911, right? Call if you're having those kinds of issues, or if a family member is having those kinds of issues. But really, an irregular heart rhythm is generally going to manifest pretty acutely, meaning they're going to have other signs and symptoms that make them look really sick. Okay. Other rhythms that can be abnormal: tachycardias, so fast, irregular rhythms, or not normal sinus rhythms, as we call them. All right. Sinus means coming from the SA node. All right. We might have bradycardia, or slow heart rates, because maybe the SA node failed and now it's the AV node. That's that pacemaker for beating our heart. Okay. Ventricular tachycardia and ventricular fibrillation. These are our two shockable rhythms. Okay. We want to defib VFib. All right, so VFib. VFib cannot produce a pulse. VFib on a heart monitor looks like this, basically. It's really, really ugly, really, really chaotic, and it's not organized enough to create a pulse like our normal sinus rhythm does, right? That's what our heartbeat is normally supposed to look like, kind of. Not perfect, but you get the point, right? And that's supposed to continue all the time. VFib looks like this, all right? That's VFib or VF. And then you have ventricular tachycardia. Ventricular tachycardia sometimes can have a pulse. Usually, it won't last very long, okay? This rhythm looks like this, all right? That's ventricular tachycardia. Notice how it is more regular and more organized than VF or ventricular fibrillation. So VF cannot have a pulse, okay? But VTAC might have a pulse. Now, will you really be able to feel VTAC? You're just going to feel a fast heart rate, right? If you can feel it in their wrist, hey, man, that means that they still have a decent blood pressure with this, which is sometimes very, very difficult, right? But if you go for their carotid because you can't feel a radial pulse and you feel a super fast heart rate, something like 180 plus beats per minute, I'd worry that we need to be getting them to ALS or to the hospital as quickly as we can, okay? VTAC is a shockable rhythm by an AED, an automated external defibrillator. If somebody is in cardiac arrest, meaning their heart is not beating, and it detects this rhythm or this rhythm, VF or VTAC, they're going to get shocked by an AED. Okay, we want them to be shocked by an AED because the best presenting rhythm we can get in cardiac arrest is a shockable rhythm. Okay, if we get a shockable rhythm, that means we can have an intervention that may help. If we have asystole, which is that flat line, okay, that is the absence of all electrical activity of the heart. Basically, it's just flat, okay? That means no electrical activity. And we know that some electrical activity is better than no electrical activity because we might be able to shock this and get our normal heart rhythm back, okay? If we have something to shock. If there's no electrical activity and they're flatlined whenever an ALS unit or a doctor or the ER staff hooks them up to the heart monitor, if there's no rhythm at all, no electricity at all, they're more likely to say, okay, not likely to get them back, okay? So if we present with a patient in cardiac arrest and it says shock advised, whenever it's done its analyzing, that's a good thing. We want it to shock, and then we immediately want to restart and resume CPR, okay? So we do our pulse and rhythm checks. Really, we don't even do pulse checks. We just let the AED analyze the rhythm every 2 minutes during cardiac arrest. If it says stop CPR, analyzing heart rhythm, and then a couple seconds go by and nobody's touching the patient, it says shock advised, everybody clear the patient, charging. And then it says, you know, fire when ready or whatever it says. It doesn't really say that, but it says shock advised, go ahead and press the orange button or whatever. You clear the patient, don't let anybody be touching them, and you hit that button, the patient's going to go just a little bit, or sometimes it's very exaggerated. But that's a good thing. We want a shockable rhythm to start with because there's more likely chance that it's going to go back into that normal sinus rhythm, a rhythm that can have a pulse and likely will have a pulse. Okay. So this right here is better than that no electrical activity. Okay. So understand that. Asystole reflects a long period of ischemia or damage to the heart. Nearly all of the patients that present with that rhythm are going to die. Okay. Nearly, not everyone, but a lot of them. Okay. It's the cessation of electrical activity, which is the basis of our heartbeats. Okay. So defibrillation restores cardiac rhythms. It can save lives, and it does. Initiate CPR until we get an AED or a defibrillator on the patient. Then we're going to follow the directions of whoever's running it, whether it be you on an AED or a paramedic on a heart monitor, like a Philips or Zoll or LifePak, right? All those different types of monitors that are out there nowadays. They hook those up and they see a shockable rhythm, makes them happy because they may actually have a chance at a CPR safe. If there's asystole and we've been working them and they start giving meds and they don't ever get a change from asystole, it's likely going to be futile, right? Or futile. Cardiogenic shock, we talked about it, right? Often caused by heart attack. This is that acute heart failure, right? Recognize shock in its early stages. Inadequate oxygen to body tissues can cause organs to malfunction. The heart lacks power to force enough blood through the circulatory system, and that's going to cause generally pulmonary edema, fluid in the lungs. Okay, so cardiogenic shock, think backup of the left ventricle. It's not pumping out well enough, and it's going to back up fluid into the lungs because the higher pressure in the pulmonary system is going to start making those alveoli or alveolar capillaries leak into those alveoli. Okay, and they will climb up into the bronchioles, and you'll hear that sound of somebody basically drowning in their own fluid. Okay, there is one fix for this as an EMT-Basic. Okay, CPAP for severe pulmonary edema, or CHF. It's supposed to be a C. Okay, so patients with CHF, congestive heart failure, especially after a fresh MI or recent MI, is going to be signs of pulmonary edema. We're going to listen to the lung sound. We're going to hear rails, crackles, all that. Right. CPAP is our goal. So CHF often occurs a few days following a heart attack. Increased heart rate and enlargement of the left ventricle no longer make up for decreased heart function. Lungs will be congested with fluid, and then it may cause dependent edema. I don't know if with this class I was able to lecture on the part where I talk about the dependent positions, but basically think with gravity. Okay, so I am sitting right now in a dependent position because my legs and my feet are bending down and my feet are up flat on the floor. Okay, that means with gravity, all the fluid, if I had extra fluid in my body, would go down to my ankles and my feet and make my feet and ankles and lower legs swell up. Okay, I would rather have dependent edema from right-sided heart failure than pulmonary versus pulmonary edema from left-sided heart failure. Right? Wouldn't you rather be able to pump blood good from the left side of your heart and be able to get around and stand up and walk and stuff like that? Or would you rather, not be able to breathe whenever you stand up to go walk to the bathroom, right? Right-sided heart failure is not as bad as left-sided heart failure, okay? However, left-sided heart failure can lead to right heart failure, okay? If it backs up in the left and it pressurizes in the lungs and fills up and there's pulmonary edema and the right side of the heart starts to back up with preload or blood returning to the heart or trying to, and it's getting backed up too, you're going to have dependent edema in your lower extremities, your abdomen, sometimes even your wrists, hands, and arms, or you're going to have left-sided heart failure and just have that pulmonary edema. Left and right, you're going to have all of the above. Okay. All right. Hypertensive emergencies. This is when the blood pressure is greater than 180 millimeters mercury. So systolic greater than 180 or diastolic greater than 100. All right. So those are the numbers that start to make us nervous when we check a blood pressure and see them. All right. I've seen as high as 280 over 180 on a manual blood pressure. Okay. Meaning I took it with a blood pressure cuff and a stethoscope. And I actually heard those numbers whenever I pumped that blood pressure up to about 300 millimeters of mercury, which is all the way around that gauge. Okay. That's as high as it goes to. I have heard 280 over 180 in a blood pressure. So maybe you are used to checking blood pressures and you're confused because you can't hear a systolic blood pressure. Well, maybe you only pumped it up 160. All right. Would you hear anything if that was the blood pressure, if you only pumped it up to 160? No. That's why we put our stethoscope here, our blood pressure cuff up here, and we pump it up and listen as we're pumping it up to wait till we hear the pulse until it goes away or we know that it's sufficiently high enough on the pump, okay, on the blood pressure cuff. Now, if I'm pumping up and I'm going, okay, it's 80, I still don't hear it. 100, I still don't hear it. Okay, I'm up to 130, I still don't hear it. Uh-oh, somebody's hypertensive. I get to 160 and I hear it. And I'm like, okay, well, I still got to keep going up. So I go to 180, 200, I still hear it. 220, 240, I stop hearing it. I'm going to stop at 240 and I'm slowly going to let that pressure out of the blood pressure cuff. And that gauge is going to go down. Okay. When I start to hear the pulse, I get my systolic. When I stop hearing the pulse, I'm going to hear my diastolic. So if I pumped up to 240 and stopped hearing it, maybe it's 230 something over 160, something like that. Right. So just understand, you might have to pump up really, really, really high in order to hear blood pressures if their blood pressure is high, right? But in the same aspect, you don't want to take a patient that's likely hypotensive or has low blood pressure and be pumping up a blood pressure cuff up to 300, okay? It's just very, very painful to their arm, especially on the elderly. And it's, if their blood pressure is low, there's no point. I mean, it's just too low to hear. We're really going by, can I even feel a carotid pulse? Are they awake? Are they altered? Do I feel a radial pulse? Right? So think about that. Some of the symptoms of a hypertensive emergency: sudden severe headache, strong bounding pulse. Remember that word bounding means super, super strong. Like feel a radial pulse and it's like thump, thump, thump really, really hard against your fingers. That's a bounding pulse. And then also ringing in the ears. That can happen from super high blood pressures as well. Common symptoms also can include nausea and vomiting, dizziness, warm skin, which could be dry or moist, nosebleeds. Okay, so remember, hypertension, high blood pressure can cause nosebleeds or epistaxis. Right? Nosebleed, the medical term for nosebleed is epistaxis. Okay, altered mental status because of high blood pressure. Not a good thing, right? We start worrying about a stroke, okay? Sudden pulmonary edema, not a good thing, right? Sudden pulmonary edema means that blood is trying to get through the heart, but the left side can't keep up. So it's going to start to fill up the lungs, okay? All right, if untreated, high blood pressure can lead to a stroke or even a dissecting aortic aneurysm. Now, you may never have heard that term before, but if you think about it, you can probably break it down a little bit and get at least pretty close to what it means. The aorta is that large artery and coming out of the heart, right? That's the aorta. A dissecting aorta is the splitting of the walls, okay, or separation of the walls of the aorta. It can cause an aneurysm that, instead of being like a tube, is now like a big old bubble in the center of the abdomen, right? The descending aorta, maybe. We call these AAAs, right? But in a dissecting aortic aneurysm, it will be severe chest pain. And if that thing tears open, they are dead in seconds. Okay. I think there's a chart in here that says the differences between dissecting aortic aneurysms and an AMI or heart attack. Just understand these patients, they need quick and safe transport. Consider ALS assistance because of the hypertension associated with that chest pain that they get with the dissecting aneurysm. Aortic aneurysm is a weakness in the wall of the aorta. It is susceptible to rupture. And a dissecting aneurysm occurs when the inner layers of the aorta become separated, like I talked about. The layers of a vessel have multiple layers. Well, if one of them starts to peel away from the other one and it starts to fill up with blood in between those two walls, it's going to be a bubble, right? And with a bubble, the walls get thinner and thinner and thinner. The thinner the wall is, the more likely it is to rupture. The more aggressive you are with your driving, in somebody who has a dissecting aortic aneurysm or AAA that could be dissecting, there's more likelihood that a bump in the road could tear it open and put them in cardiac arrest. Okay. So with these types of patients, you want quick but careful transport. Okay. We got to take it slow over the bumps, the ones that we know around our area. Entering the hospital, there's sometimes these things that, these bumps along getting into the hospital that'll shake the ambulance really, really bad if you go over it too fast. Know your area. Take it easy on those bumps, just in general, because you don't realize how much it's throwing the people in the back of the ambulance around when you go over those. But regardless, the primary cause of any one of these is going to be uncontrolled high blood pressure. So those controllable risk factors we talked about earlier, manage high blood pressure if you have high blood pressure. Okay. You don't want to die this way. Trust me. Signs and symptoms are going to be very sudden chest pain with an aortic aneurysm. Comes on full force, doesn't work its way up. It's all of a sudden acute, really, really bad chest pain. Okay. And there's going to be different blood pressures on different arms. Okay. The way that works is the anatomy of the blood flow to the left arm versus the aorta perfusing to the right arm. Okay. So you may have a higher than normal blood pressure on one arm that's not equal to the other side. You may have unequal pulses. If you just compare radial pulses, one's going to feel more strong than the other. Right? It may be difficult to tell the difference between a dissecting aneurysm and a heart attack, so transport both patients quickly and safely. I think this is that chart. Yeah, here it is. Acute myocardial infarction versus a dissecting aortic aneurysm. The onset of pain, abrupt right away with a dissecting aneurysm. Gradual with an acute myocardial infarction. Quality, excuse me, sharp or tearing chest pain. Tearing is a cardinal sign, is what we call it. All right. So if you ever hear somebody say, "Oh, my chest hurts really, really bad," oh man, it just all of a sudden it just started ripping. It feels like something's ripping or tearing inside of my chest. It's moving towards my back, like between my shoulder blades. Nice, easy transport, but get them to the hospital. Okay. We need to maybe consider ALS because of high blood pressure, right? The risk of a dissecting aneurysm getting worse or tearing open is a real concern for us. All right, and the severity of pain, again, an AMI is going to increase with time, and it's going to be full on force in a dissecting aneurysm. Timing may come and go, does not stop once it starts in a dissecting aneurysm. Region radiation, substernal, the back is really involved in a heart attack. The back is possibly involved, and pain is usually between the shoulder blades, okay, in a dissecting aneurysm. Clinical signs, equal peripheral pulses. That means we compare radial pulses on both the left and the right, and they feel about the same. Whereas blood pressure discrepancies between the arms or a decrease in a femoral or carotid pulse, probably a dissecting aneurysm, okay? Now, which one's more common? Hard to say because I didn't always get to find out exactly what was wrong with my patient in the review, right? We get to spend only a certain amount of time at the hospital transferring care over to the patient, and only under certain circumstances do we get to go like the cath lab or something and watch them get catheterized or get a stent placed or multiple stents placed. But take advantage of that opportunity if you ever get it. You just have to have supervisor approval usually, okay? So managing chest pain or discomfort. Allow the patient to sit in a position of comfort. Give oxygen if it's indicated. Right? Lower oxygen saturation would be an indication to give them oxygen. And depending on your protocol, prepare to administer the aspirin and assist with prescribed nitroglycerin. So per the National Registry guidelines, we as EMT Basics are only supposed to give the patients prescribed nitroglycerin and assist with it if we get permission from medical control. Okay. But in real life on the ambulance, I guarantee that even EMT Basics should have the ability to give aspirin and nitro via standing orders, right? Written protocols that says, if you have this in a patient, then do this, right? It's going to say, if your patient has cardiac chest pain, give them 324 milligrams of aspirin. Give them one spray of nitroglycerin under the tongue, 0.4 milligrams, or give them one tablet of nitroglycerin under the tongue, sublingually, 0.4 milligrams, right? So remember those dosages, write those dosages down, study them. Remember 324 milligrams of aspirin, 0.4 milligrams of nitro, okay? There are a few other medications that we talked about in pharmacology that we won't go over tonight, but know all of those dosages, y'all, the best that you can, because oral boards, they're going to want to ask you, hey, what's the dosage for that? Hey, how much of that do you want to give? So be ready for it. Aspirin, they say they recommend 2 to 4 tablets. Unless the patient's already just taken 2 tablets, we are giving 4. All right. So 324 milligrams is our dose on aspirin. Okay. We don't give aspirin to pediatrics, period. Okay. This is only for adults that are experiencing what sounds like and presents as cardiac chest pain. Okay. Prevents blood clots from forming or at least getting bigger, right? And platelets like to aggregate or clump together. So we give an antiplatelet to stop that clot from getting bigger. That's ASA. All right. ASA stands for acetyl salicylic acid. All right. That is the chemical name for aspirin. Okay. Nitroglycerin, there are available forms. There is a patch, like a paste that advanced providers can put on the patient's chest. We have to label it, time it, tape it, identify it, and notify the hospital that they have it on. But it saves us from having to give repeat doses of nitroglycerin as advanced providers. Usually, you are not going to have the standard of care to give a nitro paste patch to somebody. Okay. That's usually an advanced skill. Okay. Even though it's super easy to do, it's not in our scope of practice generally as an EMT basic. So we're looking at the tablets and the sprays, both 0.4 milligrams. Good with that? All right. So nitroglycerin, its mechanism, it's going to relax blood vessels, vasodilate, and specifically peripheral vasodilation, which means it's going to happen not necessarily in the heart by itself, but everywhere else in the body. Those vessels are just going to get a little bit wider, a little bit larger lumen. Okay, that's peripheral vasodilation. What does that do for us? Well, it stops our heart from having to pump so much blood. It reduces preload. Okay, so that decreases the workload of the heart. Now, preload, again, is the blood that's returning to the heart to be pumped through the lungs again, to be pumped out to the body again on the left side of the heart. Preload, if we drop it, okay, the amount of blood coming back to the heart is lower. So the pressure going into the right side of the heart and getting pumped through the lungs, the heart's not having to work as hard to get that pressure through. Okay. But if say that we have increased preload, right? That means more blood is needing to get through. We might have that heart failure, or we might be forced to move more blood with our heart, which is going to increase oxygen demand of the heart. What makes our heart hurt with chest pain? Oxygen demand versus oxygen supply, right? Our heart is basically hypoxic. It needs oxygen, and that's why it's crying out in pain. Okay. So the other thing that nitroglycerin does, it can, not always has a really big effect, but it can increase the blood flow to the muscle of the heart. So coronary artery vasodilation, all right? Coronary arteries vasodilating or increasing in size means that clot that was once in a constricted vessel, if we can dilate those coronary arteries, that clot may continue on and do less damage further down the line of the heart. Less damage or less area damaged by a clot, the less tissue that's going to die in the heart. Okay. So again, vasodilation, decreasing the workload of the heart, and sometimes it's going to give coronary artery vasodilation, as in the situation of Okay, I lost it. But that heart attack I showed y'all on the EKG earlier, right? You saw the ST elevation, and then you saw that it was back to like just a normal heart rhythm. And then just like 8 minutes later, after the nitro wears off, all that ST elevation was back. Okay. So that's the effect of nitroglycerin, right? It can vasodilate those coronary vessels. Some of the side effects, it's going to decrease your blood pressure. Okay. You reduce the amount of blood coming back to the heart, you're going to reduce the blood pressure, period. Now, is it necessarily a bad thing? No, but if it drops it too low, it definitely could be, right? It also can cause a headache. I wouldn't say severe, but think about that vasodilation. If we take a spray of nitro underneath our tongue, it's going to burn a little bit under our tongue because it's getting absorbed, and that's like the effect that has locally. But it's going to vasodilate all throughout our body, hopefully a little bit in our heart too, but also in the brain. The skull is an enclosed, closed object, right? It's only got one way for pressure to leave and pressure to come up, the foramen magnum, right? If we dilate vessels in the brain with nitroglycerin, we're going to get more blood flow to that area, increasing pressure inside of the brain, so it can give you a little bit of a headache, all right? I've never seen anybody be like, my headache. Why is it causing such a bad headache? I've never seen that, but they will go, why do I have a headache? Why does it feel like my head's hurting all of a sudden? I say, that's just the medicine working. We expect that. It's not really, it's not dangerous. It just shows us that it's in your bloodstream and it's having the effect that we expect. Okay. And contraindications for nitroglycerin. We don't give it to anybody with a systolic blood pressure less than 100. I would even be careful giving it to somebody at 108, 106, something like that. I would still be nervous, right? But our true indication or contraindication is going to be that less than 100. Don't give it, okay? Also, don't give it in head injuries or if they have taken erectile dysfunction drugs within 24 to 48 hours. Excuse me. Those meds, Viagra is the most commonly known. There's also Cialis and Levitra. So if they are on any of these erectile dysfunction medications and they've taken them within the last 24 to 48 hours, we don't give nitroglycerin because it can they can be synergistic in their nitrate effects and drop the blood pressure significantly. Super, super low. That's not a good thing, okay? Understand that erectile dysfunction medications are not just for men. Not meaning that it's going to give women erections. Meaning that women, sorry, a little bit of humor here, that women actually are prescribed it sometimes for pulmonary hypertension, okay? So too much pressure in the lungs, they take a little bit of a nitrate prescribed by a doctor, and it actually can release some of that pressure inside of the pulmonary system, okay? So understand, they're not just erectile dysfunction medications. Sometimes they are prescribed to women for pulmonary hypertension, okay? So you do have to ask, do you take any of these medications and have you taken them in the last 1 to 2 days, okay? If all you can say is erectile dysfunction meds, trust me, if a woman is on Viagra, Cialis, or Levitra, they're going to know that its primary use is in men, but they will know that, yes, I take that for pulmonary hypertension. Don't give me any of the nitro, all right? Or you should know at least, don't give them any nitro, all right? So our big contraindications, remember, for nitro, don't give it if they're hypotensive. Don't give it if they have a head injury. Don't give it if they have taken Levitra, Cialis, or Viagra in the last 24 to 48 hours. You need to remember that stuff. I would write those down. make drug cards. Y'all, there's only like 10 medications you even have to know, maybe 6 or 7 of them that you can give. So know all about them, know them inside and out. As a paramedic, I have to know upwards of 50 to 60. So just learn your few 7 to 10 drugs, and you'll know your scope, right? You'll know your abilities and what you can and cannot do. Okay. Cardiac monitoring. We're going to see a little bit of this on that virtual view in just a little bit, but just know that there are electrodes that are placed in consistent positions on the body to see the electrical activity of the heart. These rhythms are only interpreted by paramedics or advanced practitioners at a hospital. Okay. So try to minimize artifact. That means they need to stick to the patient really well. If the patient's really sweaty, we need to dry off that area that we're going to put the electrode on first, maybe even wipe it with an alcohol prep or abrade it with sandpaper tape, which is sometimes supplied on the ambulance. You abrade that area, you wipe it off with a towel, and those electrodes suddenly stick super, super well. All right. There's also something called benzoin. Super underutilized, but basically it makes sweaty people sticky. So sweaty people usually are not sticky whenever you try to put electrodes on them. It just comes right off of them. The electrode doesn't stick. You put some benzoin on that spot and that electrode is going to stick. I generally, if I carry benzoin, I use a towel to wipe off the area of that I need to put the electrode on, and then I place it, right? Wipe the area off, put some benzoin on it, and then put the electrode on, and it will stay stuck to the patient pretty well. Okay. Guiding principles: you may need to shave the body hair. So we do carry razors or electric razors sometimes on the ambulance for quick little shaves, so we can put electrodes where we need to try to detect a heart attack as an advanced provider. Now, EMTs may still have the authority to take a 12 lead or obtain a 12 lead EKG. We cannot interpret it. We do not read the doc in the box that tells us what's going on with that 12 lead. Okay. We simply transmit it to medical direction or to the receiving facility, and then we can get orders based on what they say. But there are specific places to attach these electrodes, and if you get them wrong in the wrong place, they can be misleading. They can show things that aren't really there and can cause misdiagnosis in the patient. So we have to be trained on where that EKG electrodes go before we start just putting people onto monitors, heart monitors. Okay. So then they say confirm electrode placement, that means if you're doing this, you should have been trained how and should have no doubt where those stickers go. Okay. Otherwise, if we get stickers placed backwards, it will give the wrong interpretation to whoever's trying to read it. Okay. So usually what I think is smoke over fire. So black is going to go over the red. Think of the fire on the ground and smoke above it. Grass on the right and white over right. All right. So right and white sound similar, right? So they rhyme. I think white and right, but then I think sky over grass, right? Sky is blue or white, right? And the grass is green. So white over right, sky over grass, and then over on the left-hand side, smoke over fire. So black up here, red down on the belly or down on the lower left extremity, just depending on where you're trained at your specific workplace or clinical site. And your specific paramedic will tell you where they want them, okay? Or you'll learn a certain way and just stick with it. That's just the first 4 monitoring leads, okay? So that gives us just a few views, okay? Technically, it can give us up to 6, but it really just shows us 3 real views and then 3 augmented leads, meaning they work in a different way. They show different things, but this is really advanced stuff. So we're just going through the basics: white over right, sky over grass, smoke over fire. Okay, if you can remember that, you're good. Over here is your 12 lead EKGs. We have a total of 6 stickers here and 4 over here. Okay, if you get all of them together, that is 10 leads or 10 wires, 10 electrodes, but it gives us 12 different views, which is why it's called a 12 lead EKG or ECG. Okay, so while it's only 10 stickers and 10 wires, it's actually giving us 12 leads, 12 views of different parts of the heart's electrical activity. And that's how we determine if there's some sort of heart attack going on. Okay, once electrodes are in place, switch on the monitor. I mean, a lot of the time we're already going to have the monitor on and the blood pressure going, pulse oximetry on, all of that stuff, and we're putting on wires at the same time. You don't have to wait to put on to turn on the monitor to start putting the leads on. It's just not going to start recording their electrical activity until you have the right leads on. Okay, if they say print a sample rhythm strip just to see if there's artifact would be like shaky rhythm, or a wavy bass line when it should be nice and flat all the way across. You'll see what I mean when you start doing your ride outs, or if you start working on the ambulance or in the hospital, moving on to med school, whatnot. You'll learn what artifact looks like and how to determine it from an actual bad rhythm. Okay, so don't worry about that for right now. Make sure that electrodes are firmly applied and nice and sticky against the patient, and that the cable's plugged in, at the very least. Okay. So heart surgeries and cardiac assistive devices. Y'all, these are life-saving and very, very sometimes complex, but even simple technologies that are saving lives, improving quality of life in individuals that have, say, congestive heart failure with low ejection fractions, the kind of people that are sedentary on the couch, and if they have to get up and go to the bathroom, they are exhausted by the time they make it to the bathroom, for example. Okay, so that's kind of the example I use for severe CHF. Okay, so many open heart operations have been performed in the last 40 years. There's something called a coronary artery bypass graft, also known as a CABG, CABG. All right, coronary artery bypass graft. If you ever hear somebody say, I've had a quadruple bypass, they're talking about CABGs, CABGs. That means they had 4 vessels routed around clots or spasms or blocked vessels, okay, that were not stentable in the cath lab. So what happens is they take a chest or a leg blood vessel and they sew it from the aorta to the distal point of obstruction in another vessel. Okay, so say the left main coronary artery has a blockage in it, they're going to connect a vessel that they pull from somewhere else in the body, usually the leg, and they're going to attach it to the aorta and put it around that blockage, route it around the blockage so that that vessel can still be perfused past that site. Okay. Percutaneous transluminal coronary angioplasty. Okay, this is basically PCI in a nutshell. PCI, percutaneous coronary intervention. That's what cath labs do. Okay, CABGs are performed in the operating room. Okay, PCI is performed in a cath lab, and we're going to see this procedure later performed, and the effects of it, what it looks like, and how cool it is. Really, personally, I think. So Basically, what happens is they use a balloon to inflate a narrowed coronary artery. Patients who have had open heart procedures may or may not have long chest scars. Make sure that you're treating chest pain in a patient who has had any of these procedures. Treat them the same as a patient who has never had heart surgery. Okay, still getting aspirin, still getting nitro, right? Appropriately. Make sure you're still following your protocols and asking about contraindications. You're not allergic to aspirin, are you? To the point where you can have anaphylaxis. That would not be a good day. Don't give aspirin to somebody who's deathly allergic to it. But if it gives them a tummy ache, the pros might outweigh the tummy ache. Okay, so that still might save their life. And sorry for your stomach ache, but I'd rather you live. So, all right. Some patients have implanted cardiac pacemakers to maintain a regular cardiac rhythm and rate. So these pacemakers are implanted generally when that SA node, AV node, or Purkinje fibers, or all of them have given up and are not working appropriately. Sometimes it's even just the SA node failing, right? If we just relied on our AV node, remember that's a rate of 40 to 60 beats per minute, which may not be sufficient for blood flow and perfusion, okay? Pacemaker is going to say, when the heart should fire. It's going to send electrical impulses, starting that electrical impulse for the heart at given intervals. Okay, so maybe it's set to 70 fixed. So that's going to beat 70 times a minute every day, all day, if it's a fixed rate pacemaker. Other types, there are demand pacemakers, which only kick in whenever the heart rate slows down too much. Okay. So they deliver electrical impulse through wires that are in direct contact with the myocardium. And they're implanted under a heavy muscle or fold of the skin, generally in the non-dominant side of the upper chest, which is usually the left upper portion. Here's what they look like nowadays. This technology is very reliable. Pacemaker malfunctions, though, can cause syncope or the patient to pass out if they're not working right, dizziness, weakness, and all of that due to an excessively slow heart rate. So make sure you transport these patients promptly. Consider ALS rendezvous if you need to, but recognize when a patient's heart is too slow to support perfusion of their brain and their heart. Okay, states of shock. Automatic implantable cardiac defibrillators. They call these AICDs. All right, used by some patients who have survived cardiac arrest due to VF or VFib. Okay, if they have had an episode of ventricular fibrillation and been shocked before, and that saved their life, chances are they're getting an AICD, which is sometimes the same technology appearance as a pacemaker. Sometimes they have both functions in an AICD. Okay, so they call them pacemaker defibrillators. Okay, and they're implanted same spot, either the left upper chest, or if they're left-handed, sometimes the right. Okay, and those wires run directly into the walls, the internal walls of the heart. Okay, inside the ventricles, I believe. There are multiple chamber pacemakers sometimes. So sometimes it's the atria and the ventricles that are being paced. So they still get that atrial kick and ventricular contraction. And that'll be separate shocks from that pacemaker, just very, very, very tiny voltage to set those rates at a decent level, at a efficient or effective level. Then there's defibrillator vests. This is usually a bridge to heart transplant. Okay, so a vest with built-in monitoring electrodes and defibrillation pads worn by the patient. Okay, it's attached to a monitor It uses high energy shocks. And if it warns that it's about to deliver a shock and your patient is unconscious, don't touch the patient. Okay. It usually will sound an alarm when it's going to fire. Okay. And whenever you hear that alarm or the patient hears that alarm, if they're still awake, they'll have a button to push to say, whoa, 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 hold on, don't shock me, I'm okay. All right. But if they pass out and it detects that heart rhythm and starts beeping, don't touch that button for them. Right. Let them get shocked and it'll generally restore their heart rhythm. Okay. Those are sometimes, I think the one out right now is the Zoll Life Vest. I think they talk about it in a minute. So vests should remain in place while CPR is being performed unless it interferes with compression. So just leave it on and it will still do the job of an AED basically. And then there are LVADs. Okay, LVAD, this is a bridge to heart transplant. Okay, this is that assistive device that basically is pumping blood for your heart. Okay, so it's used to enhance the pumping of the left ventricle. The most common ones have an internal pump and an external battery pack. These patients, a lot of the time, you will not feel a pulse on them because it's a continuously flowing pump, not a pump, right? It's continuously flowing, so you don't have that pulse in your wrist or in your neck, but you will hear like a humming noise over where the LVAD is in the chest. So you take your stethoscope, you place it over the left lower part of the chest, and if you hear like a humming sound on a patient with an LVAD, that means it is still continuing to pump, and it may not be the problem. Okay. Generally, they have like alarms and things that go off when they're malfunctioning or they're low on batteries or something like that. But there's a process to replacing batteries for people that have LVADs to keep them constantly taken care of. No problem, Anthony, no worries. So again, most patients won't have a palpable pulse. Transport all supplies and battery packs with the patient. I can't emphasize that enough. Last thing you want to do is show up to a hospital with a patient with an LVAD and have no extra batteries. Okay. Cardiac arrest, we know what it is: the complete cessation of cardiac activity. It's absence of a carotid pulse. Okay. And it used to be terminal, meaning that if somebody went into it, couldn't get them out. We didn't know what to do. We didn't know that there was a way to get them out of it or what exactly to do. So CPR and external defibrillation were developed in the 1960s. The more we have studied that, done research on those effects, the higher the quality CPR we've learned to do. Earlier defibrillation we found is important. And access to advanced care has become, widespread and known that it needs to happen, right? That we need to get ALS to the scene if we're working a cardiac arrest that isn't just shocked and then awake and then ready to go to the hospital. Okay. That's because that's not usually how it happens. Okay. So get ALS to that scene. All right. So this is where we stop on the lecture part and we actually get into some visual. Okay. Anything after that part that you would like to go over, be my guest, go back over, do the review, answer the review questions. It's like you're taking a quiz and it's going to benefit you. Okay, so go back to that spot and go back over that material if you need to. Okay, I'm going to close that computer up and we're going to move over to a different view. You move a couple things out of the way so we don't knock anything over. And then that's done. I can bring this back. All right, so let me show y'all a video of the cardiac cath lab real quick. All right, and then I'll turn it into the virtual look at the heart. This one's pretty quick. So a little bit of a background on this is a patient having an active heart attack, a clot that's blocking a vessel in one of their coronary arteries. Okay, this is going to show what that dye looks like whenever it's going into the vessels and not fully reaching all of the muscle of the heart with that where that vessel is supposed to perfuse. So we're going to see a short comparison of what it started as with the heart attack going on in comparison to what it looks like when there's full perfusion with that vessel. Okay, so this is a pretty short video. I hope you enjoy. Let's give it a look.
So you can see the stent material, which is a stainless steel or a cobalt chromium alloy. They're the two different stents that we now use in coronaries, and the stent is crimped on a balloon. You can't really appreciate the balloon, but it's under there because it's uninflated. What we will do is we'll put the stent in the artery over that wire, and then we will inflate the balloon, which is under the stent, and that'll deploy the stent into the wall of the vessel, and then we will deflate the balloon and pull the balloon out, leaving the stent behind in the vessel. Now the stent is in there, and you'll see the balloon inflate. And the balloon is inflating. We're now removing the balloon, which is deflated. We use nitroglycerin to treat the spasm that can occur inside the artery when you're working inside the artery. Sometimes that creates vasospasm or in the vessel. And we're finished. Both stents are deployed. The artery's wide open. The flow is excellent. And his heart attack is aborted. So that's the artery before we started. And the top is the artery following thrombus removal, balloon angioplasty, and finally intracoronary stenting of the vessel. So it's actually a large vessel. They can be sometimes deceiving. Looks small when we started, but it's a very large vessel.
So, pretty short video, but it shows you what you're going to be looking at if you ever get to go into a cath lab and follow an MI patient, myocardial infarction, an acute one happening right now, right? If you ever get to follow them into the cath lab, you'll be able to see that happen, okay? You're going to see them inject that dye, and it's only going to, perfuse or show up in just a little bitty portion, right? But once they've opened it up, stented it, ballooned it and everything, and then pulled the balloon out, left the stent in place, and then inject the dye again, bam, all of a sudden you see the whole perfusion and everything that wasn't being perfused or getting oxygen from the blood supply is now getting restored oxygen and blood flow, right? Pretty cool to watch. If you ever get the opportunity to follow an MI patient to the cath lab, beg the preceptor or your partner or your supervisor or whoever to let you go watch it, right? Because that's an experience every EMS professional, I think, should see at least once. I've seen probably a dozen of them because I love cardiac, and every opportunity I got, I would follow to the cath lab. So I worked in the ER for a while, so I actually got to help in the cath lab a couple of times, just getting them supplies and keeping it sterile and then dumping them sterilely onto the counter for them and not messing anything up. That was as far as I could do, but it was still cool to be kind of part of that team. So that's what I had to share with y'all on that. Now my last performance of the evening is going to be basically going into a virtual reality view of the heart and talking to y'all about some of the things that I'm going to mess with and some views I'm going to show you of the heart and kind of point out to you, okay? But this is the time that I'm going to turn off my video so I don't look like a goofball while I'm wearing it, but y'all should be able to still hear me, all right? This is that time that if you do have a question, I won't be able to see whose hand is up if you have it, so just interrupt me if you have a good question, but give me just a moment. And we'll get started. Is that too loud? Do y'all hear that? Is that loud? Okay. I'm going to try to share my screen. Oops, what did I do? All right, y'all able to see that? Back up a little bit and we'll get started. Sorry, it's a little laggy. That's Google Meet for you. But I'm going to try to point out some stuff for you, okay? So this is the heart, okay? We see a lot of stuff that looks familiar maybe, right? We have up here. So the end of this blue line where the two blue lines are touching, that's what I'm meaning as the tip that I'm pointing to, okay? So I'm really only going to use this one most of the time. So right over here is that right atrium, all right? Over here is the left atrium, okay? Down here you have the simultaneously beating right and left ventricles, okay? Up here you see the aorta. You can even see it even better from behind, right? You can see when it gets its pressure right after the ventricles contract and is going to send blood flow up the carotids and the subclavians. And you see the left ventricle right here doing all that work, okay? So I'm going to first show you the conduction system, but I'm going to slow down a heartbeat, okay, pretty slowly. So let me see if I can bring it a little bit closer to me so y'all can see specifically. Right there where it started, at the end of this blue line, you'll see it again in a second. That is the SA node right there. That top part is the SA node. This middle part is the AV node. And these are the Purkinje fibers that are firing that 20 to 40 beats per minute if the SA node and the AV node fail, okay? So the lower down in the heart that the electricity starts, the slower the heartbeat, okay? So this is an interesting view, right? Purkinje fibers down here, SA node right up here up top, right there. AV node right there, okay? So now I'm going to move it back. And we're going to speed up that conduction to a regular rate. So this is the normal speed that electricity is flowing in for a heart rate of 75 beats per minute. Okay, so this is at a rate of 75 beats per minute, which is a normal rate of the heart. Externally, that heart looks like this. All right, but let's think about this. If our normal heart rate is 60 to 100 beats per minute, what happens when we increase that rate to about 180? That's what it looks like. Okay. What the problem is here is that it may be beating too fast to allow refilling of the ventricles with blood between each contraction. Okay. So you see the heart rhythm down here. This is what it might look like on the EKG strip. If they're hooked up to a heart monitor, it may look completely different, okay? But let's look at the conduction system at a rate of 183 beats a minute. That electrical activity is moving very, very quickly, and that is not going to be a sustainable heartbeat for too long for anybody unless they're like a neonate, right? A brand new newborn might be beating at 180 beats per minute temporarily while it's crying or freshly born, right? Something more appropriate might be somewhere around like 140. Right? So even if you just listen to the tone of that rate, that's still over 2 beats per second. Okay? We worry about refilling of the ventricles with blood in between contractions, the higher the heart rate gets. Okay? So let's look at this. I'm going to slow the heart rate down to about 70. Here's the circulation. Okay? So you remember how I said that to the entrance to the aorta, there are 2 doors. Okay? Right here at the very end of this blue line where I'm connecting both blue lines, that is the entrance to the right coronary artery. The right coronary artery travels this way, goes down below the inferior side of the heart, a little bit on the posterior back here, and it basically perfuses all this area. But over here, where my 2 blue lines are meeting, barely, you can see it, that is the left main coronary artery, okay? If I stand up, this bifurcation that you see where it goes around and down, that is a circumflex versus the left anterior descending, which goes in the front and down, okay? This perfuses the lateral wall, and if you remember lateral, that means to the side of the body, this being the left lateral wall, okay? And part of the posterior because of that circumflex, all right? The right coronary artery doesn't bifurcate really. It splits off into these smaller vessels, but it doesn't have that really, really big bifurcation like the left main has, okay? So there's circulation. That's what the vessels look like that are perfusing the heart, okay? That's the coronary circulation. The valves. Right atrium over here, tricuspid valve. From the right ventricle, it goes through this valve right here. That's the pulmonic valve. Tricuspid, pulmonic. It goes out through those vessels to the lungs, returns through these vessels right here to the left atrium. That's this whole area. Okay. That left atrium, you see there's 2 cusps. Okay. See if I can pull it closer. Yeah. So there are 2 cusps. 1, 2. 2 leaflets. Versus over here, 1, 2, 3. Tricuspid, bicuspid. If I move it back away from me and turn it around, we see the pulmonary valve right here. That's heading to the pulmonary system. And the aortic valve right here. Okay, that's heading to the aortic arch and everything over here. All right, down to the descending aorta and up the carotids and subclavian over here. Okay, so try to pull my aorta. Tricuspid has 3. Pulmonary goes to the lungs, returns through the bicuspid or the mitral valve, and then out the aortic valve. Try to pull my aorta is how I remember it. Okay. Hopefully that helps you somewhere down the line if you have to learn or be more comfortable with the valves, but that's what those valves functioning look like. Now let's look at the interior of the heart. If I can get it to stay there. Nope. Come on. There we go. So the interior of the heart, we're looking at a few different things, okay? We see the things that are holding those valves open. versus the pressure changes that slams them shut. Okay, we know that when this valve right here, the pulmonic valve, is open, it's because the ventricles are pumping. All right, ventricle pumps, pressurizes, and then when the pressure is higher in this pulmonary artery that has deoxygenated blood in it, it slams that valve shut right there, and then the ventricle refills with blood. Same thing over here on the left side of the heart, but the blood's returning from the left atrium, right? Left atrium is coming from the lungs via the pulmonary veins, right? Returning to the heart with refreshed oxygenated blood to the left atrium, down through the bicuspid or mitral valve, and this is the left ventricle. Left ventricle pumps to the aorta. That is the aortic valve. All right. One more time at the outside of the heart. This is as simple as it does look, right? But we understand that there's a lot more to this thing going on than meets the eye, right? And we're not really going to understand that until we see something like this that can really break it down for us and show us the different functions. Conduction with electricity, the circulation of the walls of the heart, of all of the muscle of the heart, how the valves keep blood moving in one direction, how it looks on the inside with these papillary muscles and chordae tendineae. You'll hear those terms later on if you advance in medicine. Chordae tendineae, papillary muscles, all of those things have different functions. Okay, so that's what I got for you on this. Now I'd like y'all to look at coronary artery disease. Okay, so let me back up just a little bit. I need to clear this up. Okay. So what we're looking at is a coronary artery. This is a rather healthy coronary artery. Okay. Nice, smooth walls, good blood flow, nothing's clogged up or collecting in a narrowed path. But what happens when we sustain coronary artery disease? I'm going to put it about halfway up, okay? This is pretty moderate plaque buildup, all right? Calcium, cholesterol, fatty deposits, all that build up in some walls of these coronary vessels. And you can see that the more constricted it is, the more that these everything floating around in the blood is going to be constricted in this area. What can happen during an acute coronary event, right? Acute myocardial infarction, say there's narrowing that's significant like this, okay? If a small clot comes along, blocks that passageway, or say the back end of this cholesterol buildup in the walls of the vessel rip open, it can create turbulent blood flow and cause a clot here that'll cause damage further downstream. Okay, so when somebody has blockage that looks like this, they usually call it 99% occlusion. Okay, 99% because it looks completely almost filled with plaque and completely blocking blood flow. And what do they need? They need a cath lab. If it's not too severe and they don't need an actual a coronary artery bypass graft, one of those heart surgeries, the cabbages as we call them, they're going to perform a stent. And I'm about to show you what that looks like. Okay.
So remember, they said they move a catheter with a stent on a balloon. They move it into place. They'll expand the balloon, which will open up the stent, and then they'll deflate the balloon and pull it out, leaving the stent in place. And that stent is going to be repellent of platelets and clots and things like that. So let's watch it happen. Okay. The catheter is introduced. Balloon is placed in right placement. They expand it open, deflate the balloon, and pull it out. And what are you left with? A stent. Opening up, expanding those walls out of that atherosclerosis, right? Plaque buildup in the walls of the vessels, atherosclerosis, and blood flow is restored distally of that site. Okay? All right.
I hope you all enjoyed the lecture tonight. I hope it was something different, better than just reading the book, and just watching the PowerPoint presentation. Hopefully this was helpful.